So good afternoon, everybody. Today we're going to talk about a very important and a common topic about precocious puberty in boys, and we'll make a basic understanding of the overall process. We'll then talk about a very interesting case and the discussions thereof, and then we'll talk a bit about assessment, management, and other implications in that regards. A 7-year-old boy with early puberty. And what happened in this situation was that he presented basically with classical features of early puberty, had testicular volume of 4 ml, SPL was increased, pubic hair was increased. So this was a classical precocious puberty. Workup showed features of central precocious puberty, LH being high, testosterone being high. Now, this child was found to have an advanced bone age as expected and was advised a GnRH analog, which is pretty standard in terms of evaluation and management. Now, the problem is that this child presented sometime later with seizures and was diagnosed to have a CNS lesion. So what went wrong in this case, Dr. Manoj, that should have been done right in the beginning?
Sir, if we find precocious puberty, that was the central origin. So MRI should be done in every patient.
So in any boy, if you find a central precocious puberty, MRI is absolutely essential, which you should not miss. So this case really highlights that importance. Now, the second situation which we are seeing is a 6-year-old boy with recent pubic hair growth. And what we are seeing is that this boy is also tall. He is 115 centimeters and he is having a stretched penile length of 9 centimeters and a testicular volume of 1 ml. Now, what does this mean, Dr. Sayan? In that regard,
so the testis is pubertal, but the SPL is much increased.
So
they
this
aren't matching.
Anything else that you see, bone age is 6 years.
So bone age hasn't advanced.
And the height is 115. It's slightly more, but not hugely advanced.
As you mentioned, it is a recent pubic hair growth.
So what does it mean?
So chances of any carcinoma, adrenal carcinoma.
So this is a very important group of findings. If the whole thrust of this talk will be to look at just 2-3 clinical points: pubic hair, growth, and testis, and make your diagnosis. Now, in this case, what you are seeing is that you have a child who is not that tall, recent onset, small testis, and a bone age which is not advanced. So whatever has happened very quickly. It hasn't given you time. So central precocious puberty is out because anyway your testicular volume is significantly below the expected. HCG producing tumor is out because testis is very small. Possibility of CAH is also out because your bone age is not advanced. So this is something which is coming not from testis and is a recent onset. I think this is what you will get from that perspective. And what you find out here is that this child turned out to be an adrenal lesion and adrenal carcinoma. So we need to be aware about pathological causes in precocious puberty in boys. And as discussed earlier, it is slightly less common than girls, more so because girls tend to present more because it's easy to detect a breast development as compared to a penile growth or a testicular enlargement. So we have got around 1% boys. Theoretically, it will be 2.5% because it's a statistical definition, but 40% of them will have a physiological cause. So you have to be very cautious in terms of evaluation of boys with precocious puberty. So it is relatively rare, but it is more likely to be pathological, and therefore we have shown 2 cases, one of a neoplasm of the brain and the other of the adrenals, which may cause that. And this highlights the importance of careful evaluation and management in that perspective. So we'll just touch base briefly about precocious puberty in boys before going ahead with the case so that we have got a basic foundation which is made in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources on these topics, and there are a lot of videos available. We have a specific course for postgraduates, which is available, a 3-year course covering the entirety of pediatric endocrinologists from a postgraduate perspective, along with a lot of tests and examinations. There is an advanced course for people who want to delve deeper into pediatric endocrinology. And of course, we've recently launched our book, Advanced Pediatric Endocrinology, which is available online as well as on site. Now, just to summarize the overall process, we all know that the first stimulus as far as pubertal development is concerned is the GnRH, which is basically coming from the hypothalamus. And this GnRH is balanced based upon stimulatory factors and inhibitory factors. And the major inhibitory factor is GABA, which is predominating. It is suppressing. and it is antagonized by the KNDY neuron, which is the kisspeptin neuron, along with the neuropeptide Y and dynorphin and glutamate. So there is a balance between inhibitory and stimulatory process. So if you think of puberty, it's basically an act of omission or commission. Sign.
Sir, omission.
So you remove the negative feedback, so it's actively suppressed. You don't need to have something new happening. It may happen that you have an adrenal which is producing more androgens, but usually when you talk about central precocious puberty, it basically is an act of omission. Something is there which is removed, and then suddenly your pubertal progression happens from that perspective. Now this GnRH then regulates FSH, which along with LH controls the function of two different cells of the testis. Now testis has got three major groups of cells. FSH acts on the FSH receptor on the Sertoli cells, which produces AMH and all those other factors, inhibin B from that perspective, while LH is the major regulator via the LHCG receptor of testosterone production. Now, when we talk about pubertal development in boys, we are concerned about testosterone. Now, what is the relative contribution of Leydig cells, Sertoli cells, and germ cells? Now, these three are the major cells as far as testicular volume is concerned. So, Manoj, what is the relative contribution in a prepubertal child, during early puberty, late puberty, and adulthood? You can come.
Sir, Leydig cell contribution is 20%.
No, I'm talking about right from the beginning. So prepubertal, which is the major cells prepubertal? Sertoli cells are the major cells. During early puberty, 10 to 20%, which you said rightly, are Leydig cells, and 60% will be Sertoli cells. Late puberty, you have got the germ cells, which will start to increase. So if you are looking at a testis in a child who has a testicular volume up to 10 ml, 60 to 70% of it is actually coming from the Sertoli cells. So this is very, very important from a clinical perspective. So if you have to look at a single thing in a boy who presents to you with a precocious puberty, is to look at testicular volume. If the testicular volume is normal or commensurate with regards to pubertal development, it would mean it's a central precocious puberty. If the testicular volume is absolutely small, like in case 2 in which we discussed, this is a peripheral precocious puberty. Now you can have in between situations as well. If you have a slightly enlarged testis, but your pubertal development is much more. So let's say you have got a testicular volume of 8 ml and your pubic hair 4 or 5. What does that mean, Dr. Pratik?
So, some form of LH stimulation, Leydig cell stimulation is this probably an HCG tumor.
So it basically would mean that this is predominantly a Leydig cell phenomena. So you have got an isolated LH excess like HCG producing tumor, or you have a testotoxicosis, which is basically an activating mutation of the LHCG receptor. So large testis is central precocious puberty, small testis is adrenal cause, intermediate testis, which is not more than 8 ml. Not more than 10 definitely, but less than 8 ml with stage 4 or 5 pubic hair development. Start thinking of two possibilities. One you have very clearly talked about is that of a LH dependent state or an isolated LH excess. The second would try and be that's the same LH. Anything else? Which is very important, which we saw in your case.
So one is central CH triggering central.
So peripheral precocity, if it is for a long duration, will trigger the central precocity. So this again will be the second possibility. So testicular volume by far is the most important thing to look at in a child with precocious puberty. Now, if we look at that, the testosterone, of course, is converted via 5-alpha reductase to DHT, and this is, we already know about that situations in that regards. And very importantly, the testosterone is aromatized into estradiol, and estradiol is the major regulator of growth spurt as well as epiphyseal fusion. So when we talk about treatment of peripheral precocious puberty, we'll talk about the possibility of actually using aromatase inhibitors, which will decrease the conversion of testosterone to estrogen, and that may help in that regard. So it's estrogen which is causing epiphyseal fusion in boys as well as girls in that regards. Now, very importantly, the adipocytes also are very important sources of hormones, and they produce leptin, which is regulating the pubertal development. Does obesity cause early puberty?
Yes, obesity causes early adrenarche, but not early.
Yes, very important. So obesity will increase your leptin level. Now, leptin is not going to induce your puberty. It will allow, if the body is ready, whether your bus can go through this toll, that leptin will decide. But just because your toll is up, your bus doesn't have a fuel, it can't cross through. So a boy, just because his leptin is high because of obesity, will not enter into gonadorrhea because there is no other signal. But yes, because of this obesity, your DHEAS production will go up, so you will have adrenarche. So this is an unusual situation in which you have got just the pubic hair development with small testes. So small testes with pubic hair development, again, a possibility of a obesity related cause is very, very important, which you have to consider in that situation. So of course, leptin will trigger that. The second source, of course, we have discussed about is coming from the adrenals, and it produces DHEAS, which is converted into testosterone. Now, this is what I was talking about till now as to how to determine etiology just by looking at a testicular volume. So now if we say we have a central cause, we have discussed that you will have increase in both Sertoli as well as Leydig cells. So this will mean that the testis will commensurately increase. So if you look at the chart in which you have got the pubertal status and testicular volume, if you compare that, it will be commensurate to that level. So first thing will happen is the testicular enlargement, then pubic hair development will happen in that perspective. Now, if you have situations wherein there are specific issues which happens in that perspective, there are some other situations in which you can have variable situation. Now, TSH is going to act on which receptor?
FSH.
FSH. So TSH has an overlap with FSH. So TSH will bind to the FSH receptor, and that will cause predominant Sertoli cell growth. But your testosterone production will not increase. So what will happen in that situation is that you will have large testes, but your pubic hair and penile growth will not be there. So we said in obesity, you have pubic hair growth and no testicular enlargement. The opposite of that is large testes with no penile growth. This is hypothyroidism. And if we compare this to 1Y Grumbach syndrome in girls, it's the same. You have a large ovarian cyst which is there, but no pubic hair growth. So large testes, no pubic hair growth, consider the possibility of hypothyroidism as an important cause, and this is the presentation with macroorchidism. Now, if you have a HCG producing tumor, or there is an issue of isolated LH excess, what will happen is that Leydig cells will go up. But since HCG or LH does not have an effect on the Sertoli cells, they will not increase. So what you will see basically is that the testicular volume will slightly increase. Never above 10, usually around 8. So as I said, there will be a discrepancy between testicular volume and pubertal development which is there, and penile size will increase in that perspective. There will be intermediate testes which are there. If you have an adrenal source, of course, it will have all the production is coming from there. So testes will basically be small. Because why will they be small? Is because your testosterone will inhibit the LH production, and therefore your testicular size will go down in that perspective, while the penile size will increase. So again, I am focusing time and again on the testicular size being the most important thing to look at in a child with precocious puberty and small testes. So if you have therefore a normal size testis, central precocious puberty, small size testis, peripheral precocious puberty, macroorchidism with no pubic hair development, hypothyroidism, and intermediate testis is HCG producing tumor or testotoxicosis which is there. We'll discuss about all the cases gradually. We all should be aware about how the pubertal development happens, and very important thing to remember is that you will need to have first the testicular volume to increase, because then only testosterone will come in and then pubic hair growth will happen. So this is a normal development. By around 10 to 15 only, you will start to increase the pubic hair. So if you have this pubic hair 4 stage with a testis which is somewhere around like this or this, there is something abnormal. You should start thinking whether it is a HCG producing tumor or whether there is a possibility that there is a triggered puberty, which becomes absolutely important in that regard. So again, always look testicular volume and pubic hair in a simultaneous situation, and that becomes very, very vital and important from that perspective. Now, what really is precocious puberty? Any onset of pubarchy or a testicular volume which is earlier than 9 years of age is considered to be early puberty. Remember, penile size is not given that much importance here because of measurement issues. But if you are very sure if the penile size is increased, there are nomograms available, you can also use that. But predominantly, we're talking about pubarchy and testicular volume. Why are we talking about pubarchy? Is that suppose you have a peripheral cause, testicular volume will not increase. But if your penile size is increasing, it is not going to happen that your pubarchy will not happen. And it's a much more objective criteria to look at in that regards. Now, within this framework, we can now understand the classification of precocious puberty. The problems could be from the hypothalamus, which is basically acts of omission. The problems are associated with a high level of LH. And when we say high LH, we are talking about levels more than 0.2. So if you're doing these modern chemiluminescence assays, they are very good. If the levels are more than 0.2, it clearly would mean that we are dealing with a case of central precocious puberty, while if the LH is less than 0.1, it is peripheral. So the role of routine GnRH testing is often not required. Now, just as an important practical tip, as against girls where there is a lot of fluctuations in terms of levels, in boys, the LH will be very high. So you will not be in much doubt whether it is central or peripheral. Usually it is not going to happen. In girls, you can have that transient situation, which is confusing. The peripheral form, as I discussed, low LH will be the best indicator in that regards. Now, if there is any disruption of the hypothalamic axis by a tumor, by a radiation, trauma, or insult, you will have a possibility of a precocious puberty. If you talk about radiation effect on puberty, because hypothalamus is more sensitive, if you give dose between 18 to 30, typically that 18 to 30 gray will cause a precocious puberty because inhibitory signals of GABA will go off. Beyond 30 to 50, you will start having actual delayed puberty, and you may actually have early puberty followed by delayed puberty, which is very, very important. Now, is testicular volume a reliable sign of pubertal onset in somebody who has received total body irradiation?
So total body irradiation central is gone, so the testis size will not increase.
If you have a precocious puberty?
So if the child is getting a low dose, then obviously the testis size will increase.
That's what I'm asking. Is it a reliable marker or not? Pratik?
It is not a reliable marker. It may be falsely low if you are checking that.
Because they will be damaged to the germ cells and they will be damaged to the Sertoli cells. Leydig cells are the last to go. So don't just go by testicular volume in that setting. So what will you look at? LH?
Testosterone levels and SPL.
LH again is not a good marker because you may have some Leydig cell damage also. So LH may be falsely high. So the best thing is to look at testosterone level. So if you have somebody who has received radiation, both of the brain as well as scattered radiation of the gonads, don't go by testicular volume, don't go by LH levels, go mainly by testosterone levels and features of virilization like pubic hair as well as penile size. This becomes important from that perspective. Now, peripheral precocious puberty can be because of a congenital problem in the adrenals, which is starting to produce a huge amount of hormones, or if there is an acquired tumor. So we discussed in the second case, adrenal tumor may be a possibility which may cause that. There could also be a problem in the LHCG receptor, which could be testotoxicosis or a McCune-Albright syndrome, which may be there. So this is the basic etiology. I would say if you talk about major causes, organic CNS pathology, maybe 40-50%, CH, again 40%. Tumors are very, very rare in terms of adrenal carcinoma, but very important. These will be missed. Why? If you remember the second case, recent onset development, no height increase, no bone age increase. People will say, okay, it's fine. But that means that this may be worse in that perspective. So a recent onset pubertal development, I will be more worried in that situation, especially with a small testicular volume in that regards, which will happen in that perspective. So we've discussed a lot in terms of theory. We'll just show you this slide and then we'll start off with the case. So testicular volume is the most important indicator of source. If you have large testes, this is
The central.
clearly central. What about this? Small testes with precocious puberty, typically peripheral. We are talking about intermediate testes up to 8 to 10 ml with a pubic hair 4 or 5. You're thinking of a possibility of a HCG dependent cause, either a HCG producing tumor or a possibility of a testotoxicosis. What about this? Leydig cell tumor, which is producing testosterone. So these will be the possibilities. Now, so how do we go forward in terms of investigations? So the most important investigation clearly is testosterone, which will of course be high in most cases, and LH. So always look at testosterone and LH in parallel. And your case shows that if your testosterone is high and LH is pubertal, but it's just borderline, it is still peripheral. It is not central to begin with in that regards. Of course, FSH will have some value, but I would say LH and testosterone are the most important. Usually in boys, we don't need to do a GnRH test in most cases, except for these triggered cases. Now, in your case, we could have thought, okay, it's 0.21. Let's see how much it is rising, but it wouldn't have changed your management. So in that situation, you might have thought that in that perspective. So basal more than 0.2 or 0.3, or you with GnRH and you see a level which is going above 5, this becomes significant in that regards. And we are now going more towards a single ratio of 5 rather than a ratio in that perspective, but both criteria are there in that setting. Now, MRI, any boy with central precocious puberty, first case tells us if you don't do it, that's like criminal. You have to do an MRI in all boys and girls less than 6 years of age, which is absolutely important. Adrenal cause, you have to obviously do a CT scan. And a big warning, you may miss adrenal carcinoma. So do a very careful abdominal examination. Ultrasound will miss. I have also missed on ultrasound, and then on CT, we found that. So it's very important to consider CT scan in that setting. Of course, 17 OHP, and if the blood pressure is high, think of a 11 hydroxylase that will become relevant from that perspective. And in that regard, it will become important from that situation. And bone age, of course, will tell you how it is progressing. So if we now go into the approach, the first step is to confirm precocity. And if you are looking at precocity, we're mainly talking about pubic hair development. If the penile size is documented to be very increased, testo is high, bone age is advanced, then you do gonadotrophins. If gonadotrophins are high, this is central, you have to do an MRI, no confusion. If it's peripheral, low, do adrenal imaging. Now, this is important. Often people miss that. Do adrenal imaging. If you find a tumor, you will identify. If it's enlarged adrenal, it is usually CAH. And if it is normal, then you think of rarer causes like HCG producing tumor, or then finally you will think of a LHCG receptor genetic study. But most cases will come here. You will think of a high MRI head, or you will see an enlarged adrenal 17 OHP high like this case. So this is a classical presentation. Now, Dr. Prateek, if you can just quickly go through the cases for discussion.
Thank you, sir. So 4-year-old boy presented with early puberty. Now this was the clinical picture.
So what do you think?
So we have a boy who has high testicular volume and HPL is also increased. I would consider a central precocious puberty for this. Yeah. So then gonadotropin levels were done, and LH is 2.2, FSH 3.2, and testo is high. So suggesting a central precocious puberty. So then there's of course MRI head was done.
So what was the MRI showing, Manoj? What do you see here?
Early age present.
No, what is the MRI showing? you go by age or you go by MRI picture? Cyan?
Yes.
So hematoma.
Where is the hematoma? So hematoma is basically normal tissue in abnormal region. So if you see, there is a hypothalamic tissue not in the hypothalamic area. So this is a hypothalamic hematoma. So this will be an early onset presentation, and typically what will you do now? You will send to neurosurgeon? There is no role of surgical intervention, only if there is refractory seizures and other features you will think of, but that is not common with this location of the hypothalamic hematoma.
A 7-year-old.
So this was the case we presented in the first case, and this again highlights the importance that if we had looked carefully, we might have found cafe au lait spots, we might have found neurofibromas, but forget about that. Any central precocious puberty, get an MRI. Otherwise, you will land up like this situation. So this is very, very important.
A 7-year-old boy with early puberty. Now, what we see here is clinical picture is quite different from the first case. Here we have an exaggerated growth of the penile end, and the testicular volume is small compared to the penile end. So, which is more suggestive of precocious puberty, peripheral precocious puberty. So, in this case, of course, gonadotropin deviations are done, which were low. LH were probably low, and then adrenal imaging was done, which showed a lesion. And of course, in this LH came 0.1, FSH was 1.2, and testo was 200. So
you have a large adrenal with peripheral this thing. So obviously the next step will be 17 OHP. This is just like this case, which we just discussed. You carry forward.
So in large adrenal, we did 17 OHP and it came very high, suggestive of 21 hydroxy deficiency. Now this child was started on hydrocortisone and fludrocortisone, and 6 months later it was noticed that the testicular volume enlarged to a pubertal age and bone age was 11 years. So, and testosterone actually came down from the previous level. So
this is just like what Sayan had been discussing, a classical case of secondary triggered precocious puberty. So keep your eyes and ear open. So normal 17 OHP, high testo means central precocity.
So, and then because there was doubt of whether it's central or not, a stimulated level was done, which was 8, so it was triggered central precocity. A 5-year-old boy with early puberty, and here if we see the penile length is much more than the testicular volume, and here again gonadotropin levels were done, LH 0.1, FSH 1.2, and then adrenal imaging were normal, and then so here what we see here is the testicular volume is not as small as the previous image, it is intermediate size. So then HCG levels were done, which were high, and then a CT chest and imaging showed that there was a lesion, suggestive of a HCG producing tumor.
So if you have anybody, as discussed, with the intermediate size, this thing, you have to do that. And this was a classical case. We discussed the second case. Very importantly, adrenal imaging was very important. You may think, okay, we can do 17 OHP first and then imaging, which is okay. But don't forget about imaging, and imaging has to be CT. Don't go by ultrasound, otherwise you will miss this adrenal carcinoma, which is there.
A 3-year-old boy with early puberty, height is 106 centimeters, weight is 14 kgs. SPL is 9 centimeters, and pubic hair is 3, but on the other hand, testicular volume is just 3 ml. So here we have SPL which is high, pubic hair which is high, but testicular volume is still pre-pubertal. Now gonadotropin levels were done, which is as expected, LH is suppressed, and testosterone is high, suggestive of peripheral precocious puberty. CT abdomen was normal. So the next step is basically 17 OHP was normal and HCG levels were normal. And what is remaining is the LHCGR receptor, any Leydig cell dependent.
So this testicular volume is slightly higher than what you will see for peripheral precocious puberty. So again, this is indicating towards a possibility of a intermediate size and a HCG or a LH dependent cause. So testotoxicosis, because it's too early. If you wait for a few years, TB will go up a bit, but this is a classical presentation. Yeah. Thanks, Dr. Pratik. So to carry forward with regards to the overall management, the options as discussed include the use of GnRH analog, and GnRH analogs are basically going to flood the hypothalamus with a huge dose of GnRH, and the pituitary will get desensitized. It will not going to produce any further amount of gonadotropins in that perspective. You can use hydrocortisone, of course, which will improve. There will be a role of anti-androgens, but that is mainly for testotoxicosis. It is not routinely for CH. And you can think of a surgery for HCG producing tumor. If there is a germinoma, radiotherapy will be very effective in that regard. So if we now look at CH management, as discussed, the key treatment mainly is in terms of giving hydrocortisone. Now, as you give that, your DHEAs will come down, testosterone will come down, and then you will have a central triggered puberty. In that setting, you have to do something you have to give GnRH analog in that regards. So you have to monitor your testicular volume, maintain testo below 20. So your testo was below 20, but because we were monitoring LH, we got to know that, okay, TV is going up. So it's an early diagnosis. If he had waited, he'll just present like a central precocious puberty later on in that perspective. And growth hormone may be considered if it is very, very much compromised, not on a routine basis in that regards. What about testotoxicosis? The options include anti-androgens and aromatase inhibitors. So you're basically blocking androgens and you're blocking its effect on growth via aromatase inhibitors. So just to summarize now, very important, any boy with development less than 9 years of age is early puberty. There's a 40% chance of pathology. You may miss a CNS tumor, you may miss IHCG producing tumor, you may miss a adrenal carcinoma. Testicular volume is the key. If it is very small, peripheral, large, it is central, intermediate, it is HCG, unilateral enlargement, we're talking about mainly a testicular tumor. If the testes are big and there is no pubic hair, it is hypothyroidism. So this combination becomes important. Basal LH is very, very important, and GnRH analog, of course, will have role in terms of treatment. So this is an important topic, and you can go and have a look at our website to look at the various parameters and explore our courses for postgraduates and our application also, which is there, and the books which are available. So I think we'll close down in terms of the overall presentations here. We'll see if there are any particular questions which are there, and we'll carry forward from that in that regard. So Dr. Mudita is asking how reliably the height predictions are done in these studies. So I think we have to agree that these height predictions are not very reliable. They tend to overestimate. But if we look at the final height, which is in the range of the parents, I think that's a good enough parameter to find in that regards. There is, of course, an issue if you have an advanced bone age, you can't really rely on the prediction. But of course, if your bone age is 13 and your height is around 8 years, you are very compromised. And if you reach a normal height, I'll be very, very happy. Now, according to algorithm, you suggested adrenal CT for all PPP. I think this is a bit of a, it's a very important point which Dr. Rajesh has raised. I said that second option is that you can do 17 OHP. If 17 OHP is decisively high, you should do that. But sometimes I've seen is that you can have high 17 OHP in adrenal carcinoma also. This is important because it is producing a large number of steroidogenic products. Your 17 OHP may be falsely high. So if your 17 OHP is like your case, it's like 20,000 nanogram per DL, be happy. You don't need to do imaging. We did not do an imaging in this case. So I agree that you do 17 OHP. If it is very high, avoid imaging. But if the 17 OHP is borderline, think of a possibility of adrenal carcinoma. How will a girl with LHCG receptor activation present? Now, I think this is a question which we will discuss a lot in terms of physiology. So LH has very limited role as far as pubertal development in girls is concerned. Its major role is ovulation. So LHCG receptor defect will present with normal puberty and anovulation. LHCG receptor activation will cause nothing in a girl. I don't know whether it will cause more problems in terms of a high LH state causing a mild hyperandrogenism, but not in the setting of a precocious puberty in that regard. So that's why HCG producing tumor or testotoxicosis equivalent. There is no overtoxicity in that regards, so to speak, in that perspective. So I think these were a few questions. We'll see if there are any other question. So there is a question from Dr. Purnima. When do we decide to add prednisolone? So I think that was more in regards to uncontrolled CAH. So if you have somebody whose final height is complete and yet you are developing testicular tumors, which are their adrenous tumor, you can think of a more potent steroid like prednisolone in that perspective, but not before the final height is achieved. Dr. Sanju is asking, should fine lightly pigmented hair in mustache area, upper arms, back of trunk in a female considered significant for hyperandrogenism? No, it's very important. It has to be coarse, thick, pigmented hair. So I would not count them because otherwise you will unnecessarily start working in a large number of cases where a workup is not required. Dr. Candy is asking, how does hypothyroidism cause peripheral precocity? So hypothyroidism is not really causing peripheral precocity in boys. If you have very high TSH, the TSH will act on the FSH receptor. Sertoli cells will become bigger, so testicular size will increase. So they may present with high testicular size with no other features of puberty. So it's the opposite, or it's a mirror image of the von Wieck-Grumbach syndrome, in which you have a large ovarian cyst with development, with again pubarchy is not happening. Now, Dr. Ronke is talking about, explain again how glucocorticoid will cause precocious puberty. Yes, so this is again an important question. What we are saying is that if you have congenital adrenal hyperplasia, it is predominantly the adrenals which is producing the testosterone. Now, because of this very high level of testosterone, the pituitary is suppressed. LH-FSH levels are low, but the bone age is increased. So the body is ready for precocity. It is not entering precocity because of the suppression by testosterone. As soon as we give glucocorticoid, the suppression goes off and suddenly the pubertal progression increases. So by giving treatment, you may trigger, or you may, let's say, unravel the precocious puberty which was hidden. This is what will happen. It's not that it is causing, it was already there. It is manifesting once you start steroids in that regards. I think there's another question from Dr. Rajesh. At what time of the day Hyson dose should be given, morning or evening? So there are a lot of studies which say whether you give higher dose at night, higher dose at morning, there is no difference at all. Generally, if you give it 2 to 3 times, ideally 3 times a day will be better. Equal dosage has got equal effect, because remember, it's not that you're releasing the hormone, it's going to the CBG, the cortisol binding globulin, it is releasing gradually. So it's not that diurnal variation will have a huge impact. So you give it 3 times a day is the best with equal distribution. I think reverse DEXA use has no advantage. This was tried earlier, but this is now clearly of no role, Dr. Pankaj. It's not recommended anymore. So it's not very beneficial in that regards. But yes, dexamethasone may be beneficial over hydrocortisone or prednisolone in controlling hyperandrogenism, particularly in adolescent girls who have got very high testosterone levels. So if there are no other questions, we can probably, which generation analogs in CPP? So again, leuprolide or triptorelin, both are the good options which are available.